Okay, so for the anatomy of the female reproductive tract, for endometriosis, we're mainly focused on the internal anatomy of the reproductive tract. So that includes the vagina, the cervix, the uterus, which has three layers: the perimetrium, which is the outermost layer, that is the serous membrane. The middle layer, the myometrium, which is the muscular membrane, and then the innermost layer, the endometrium, which we're mostly talking about today. That is what is the uterine lining, and it has two layers: the functional layer, which is responsive to sex hormones of estrogen and progesterone, and it proliferates and sloughs off monthly during the menstrual cycle. And then there is the basal layer, which is attached to the myometrium, and that is what regenerates the functional layer after it sheds. And other portions of the internal female reproductive tract include the fallopian tubes and the ovaries. There's a lot more, as you can see in this picture, but we're focused mostly on the uterus and the endometrium for endometriosis. So for endometriosis's disease process, it's important to kind of talk about the hormones that affect the endometrium lining. So the two big ones are estrogen and progesterone. Estrogen is the generic term for three hormones: estradiol, estrone, and estriol. Estradiol is the most potent and plentiful, and its job, the estrogen's job, is to, in the endometrium, it stimulates growth, increases the number of progesterone receptors, the maturation of reproductive organs, the development of secondary sex characteristics, and the growth and maintenance of pregnancy. It also has many other jobs in the rest of the body. In the bones, it deals with the closure of long bones in both males and females. It maintains bone density. It decreases LDL and increases HDL in the liver. And in the neuro section, it improves memory and cognition. In the skin, it helps with collagen, elasticity, and the healing ability of skin. And the next is progesterone. This hormone stimulates the endometrium to prepare for implantation. So it's stimulated by the LH surge that occurs right before ovulation. And so the LH stimulates the corpus luteum to secrete progesterone. And in pregnancy, the progesterone is responsible for maintaining the thickened endometrium and also relaxing the smooth muscles of the myometrium and thickening the myometrium. And it also promotes the growth of lobules and alveoli in the breast so that eventually milk is produced there. And overall, the progesterone acts on the endometrium to activate the glands, the blood vessels, increase glycogen and enzymes. So it's just stimulating all the nutrients and blood supply necessary to maintain pregnancy. Now we move on to the pathophysiology of endometriosis specifically, and this disease is basically the proliferation of endometrial tissue. Endometrial tissue can move out from, it can occur not in the uterus where it's supposed to be, and the estrogen and progesterone and FSH and LH can also act on this endometrial tissue that's outside of where it's supposed to be, and then this leads to breakdown and bleeding when the hormones rise and decrease. And this leads to a cascade of inflammation because it's in the wrong spot and bleeding's happening. The body's not equipped to deal with this bleeding in the wrong spot. So it leads to inflammation, which leads to the pain that a lot of people experience with endometriosis. And then because the body's trying to repair the tissue that's in the abnormal areas, it leads to scar formation or fibrosis. Endometriosis can be considered as a chronic inflammatory disease because these hormone changes occur monthly with the menstrual cycle, and so the pain and bleeding also will occur as the menstrual cycle hormones change. And so these abnormal tissue, the endometrial tissue, can occur. This picture shows some of the most common areas that it can occur. So near the bladder, around the ovaries, near the fallopian tube, and then it can move upwards towards the GI tract. It has ectopic endometrium has been located as distant as in the brain. So they do spread through the circulation, kind of similar to how cancer does. And the growth and proliferation of these lesions depends on how much estrogen it's exposed to. Common signs and symptoms of endometriosis include chronic pelvic pain, dysmenorrhea or pain during menstruation, dyspareunia or pain during intercourse, pain with bowel movements or urination, and this can worsen during menstruation, menorrhagia, which is heavy menstrual bleeding, irregular periods, tenderness in the pelvic region, palpable masses or nodules, and infertility. Diagnostics include there's no specific blood tests to diagnose endometriosis. There is sometimes the CA 125 levels are elevated. The CBC can show anemia because of the heavy bleeding. Hormonal levels sometimes can indicate when they're elevated, estrogen, progesterone, or the FSH and LH, but it's not always indicative of endometriosis. And then imaging can be done, like a transvaginal ultrasound, an MRI, and laparoscopy is the gold standard. It's the only way to really tell by putting a scope down through to find the endometrial tissue that's in the incorrect spots. And then biopsy can be done, tissue when the scope is inside, tissue can be sampled for biopsy. And then these signs and symptoms, since a lot of it is dealing with pain and bleeding, these can lead to worsening mental issues such as depression, irritability, anxiety, anger, and then feelings of helplessness, especially if the pain is chronic. And then it can cause you to miss work, school, strain relationships. Yeah. So these are just two examples of laparoscopic endometriosis repair. The first the first set of pictures is showing endometrial tissue in the ovaries that's been repaired, and then the second example is showing endometrial tissue by the diaphragm. So these are just two examples of how far it can travel and how it kind of looks laparoscopically. So some of the etiological factors for endometriosis are early menarche, which is the early onset of menstrual cycles. Frequency and the severity of disease are greatest among women who have a female relative with endometriosis, which suggests that there's a genetic susceptibility. One of the theories is retrograde menstruation, where endometrial tissue passes backward through the fallopian tubes and spills into the pelvic cavity. But this isn't necessarily true. It's necessarily causative for endometriosis because retrograde menstruation occurs in almost all women who menstruate, but only 5 to 10% develop endometriosis. Congenital reproductive tract outflow obstructions also increase the risk for endometriosis because just the way the reproductive tract is structured in these malformations, it's obstructed and the tissue can't leave as it should. There's also some evidence that being immunocompromised or having immune system dysfunction leads to the body not effectively killing this endometrial tissue that's in the abnormal areas. And there's also genetic or environmental factors that can cause irritation and induce the endometrial cells to mature outside the uterus. So risk factors for endometriosis include having a family history, having a female relative like mother, sister, or daughter with endometriosis that increases the risk. Age, so women between 20s to 40s, but most occur between 25 and 29 years of age, and it's more common in Caucasian women. Nulliparity, which is women who have not given birth, they're at higher risk. Having early menarche, short menstrual cycles that are less than 27 days, or heavy and prolonged menstruation. And then hormonal influences, so having high levels of estrogen or estrogen-like chemicals can contribute to higher incidence of endometriosis. So for the case study, our patient PN is a 29-year-old white female married to her husband of 9 years, and she currently has 2 children and is trying for a third. She comes into her gynecologist's office and she's complaining of severe lower abdominal cramps. She tried over-the-counter ibuprofen and acetaminophen, but they did not help. And then she currently is on her menstrual cycle, and the pain began about 3 days or 72 hours ago. So she also explains that she's had 2 weeks of sharp, deep pain during sex, mild lower back pain, and pain with urination. She later also mentions having some heartburn. Her past medical history includes 1 episode of a UTI 4 years ago, rheumatic fever at the age of 10, and no complications. She also endorses a family history of having a mother with hypertension and cancer, and also her maternal grandmother has leukemia, breast cancer, and endometriosis. On her father's side, her father has hypertension, kidney stones, genital herpes. And then her lifestyle includes a low-fat diet. She does watch her weight and exercises regularly. She plays softball and bowling, and she does not smoke or drink alcohol. So she also denies having any blood in her stool, any pain with defecation. She denies heavy periods, intermenstrual bleeding, so bleeding between her cycles, diarrhea, constipation, and PN started having her menstrual cycles at 13 years of age. PN's physical exam was mostly unremarkable. Almost all her systems were normal. Her constitutional, it is noted that she's in mild acute distress. Her pelvic exam shows some tender cervical nodules, and her pap smear is pending. And neurologically, she's slightly anxious, but otherwise everything else was normal. And then her labs are also all within like normal limits, except for her ESR, which is slightly elevated at 17. So PN symptoms of pain with her menstrual cycle, pain during intercourse, and family history of endometriosis. indicates differential diagnosis of pelvic inflammatory disease, ovarian cyst, endometriosis, adhesions, primary dysmenorrhea, secondary dysmenorrhea, myoma, cervical stenosis. And those are like the reproductive kind of diseases. Other diseases that she possibly potentially other like syndromes she potentially could have are irritable bowel syndrome, constipation, inflammatory bowel disease, interstitial cystitis, chronic urinary inflammation, and then there could also be neurologic or psychosomatic causes. These are a little lower on the differential list just because they don't match up as much as the reproductive diseases. So for PN's potential treatment plan, laparoscopy is required to make a definitive diagnosis. And then if we presume that it is positive for endometriosis, and while they're in there, they can excise or ablate any ectopic endometrial tissue. They can also, so medication can be used to treat, to prevent the progression or spread, but there's no cure for endometriosis. So some of the meds include combined hormonal contraceptives to suppress ovulation, progestins such as a pill, injections, or IUD, and then further treatment for more resistant endometriosis can include GnRH analogs to stop FSH and LH, and danazol that diminishes the LH surge right before ovulation. But these two meds have many side effects. And then we can use pain control, and NSAIDs are first line for endometriosis. However, since PN's pain has shown that it's not really responsive to over-the-counter ibuprofen, other stronger NSAIDs could be used. Also, pelvic floor physical therapy can be used. Other treatments for endometriosis, especially if it's severe, include partial hysterectomy, as well as total hysterectomy, and bilateral salpingo-oophorectomy, which includes the complete removal of the ovaries and the fallopian tubes and the uterus. Potential complications of endometriosis include poor obstetric outcomes, such as miscarriage, ectopic pregnancies, preterm birth and placental complications, small for gestational age babies, and that's if pregnancy can be achieved. Another complication of endometriosis is infertility. There's also an increased risk of cancers, especially ovarian cancer. Other complications include that endometriotic lesions can come back. Even if they're excised, the tissue can grow again. There's also chronic pain. Excision does improve pain, but this isn't true for all patients. So it can have chronic pain. There can also be gastrointestinal issues, and other organ systems can be affected if the endometrial tissue has proliferated to those areas, spread to those areas. And then these complications can lead to severe mental health crisis, such as depression, because it impacts family planning, productivity at work, sexual well-being, just overall quality of life can be affected. So it can lead to worse quality of sleep, lower physical activity. It can contribute to a lot of other issues. So for PN's progression and outcome, it's necessary to have early detection, especially because the mean delay of definitive diagnosis is approximately 10 years. So it's really necessary for her to get screened
immediately or as soon as possible. It's also important for PN to adhere to her treatment plan, so whatever medications are prescribed for her, and then also keep following up because it's really common to have recurrence of endometriosis. And it's also, if she does end up having surgery, she needs to adhere to the post-surgical instructions to avoid any complications or infection. Then PN is also interested in having a third child. She really wants one, which is why she's seeking treatment at her gynecologist. So IVF might be necessary if this is impacting her fertility. And then long-term pain management might be necessary if she does end up having chronic pain, or physical therapy might be necessary.